Okay, so I have three cases to discuss with you, all on the same topic of cerebral venous sinus thrombosis and trauma. And each case has got some important features for us to discuss, and we'll look at the literature to see how that helps us make decisions. So the first case is a 58-year-old man. Yeah, 58-year-old man, apologies, sorry. He fell 12 feet off a ladder. Initial GCS was 13. He was a bit agitated and he vomited, and he was intubated. He had these images. It was an isolated head injury. You can see he's got a diastasis of his right lambdoid suture extending into the mastoid. He doesn't have much fluid in the mastoid. There is a little bit of fluid in his middle ear, but that's about it. And on the brain scan, he has some frontal contusions on the left. He has a thin tentorial subdural, and he has some blood around the right sigmoid venous sinus. It was relatively mild radiological and clinical injury. There's nothing there that would really have required surgery, and he was managed in his peripheral hospital, even though he was intubated. The following day, he was still a bit agitated, and he had a follow-up scan, which didn't really show any major difference to the first scan, and I haven't really reproduced it. But on on day two, he had a clinical change. His pupils stopped working, and his brain scan had changed quite significantly. He had a lot of general cerebral swelling. His frontal contusions had blossomed and evolved. He had some subarachnoid hemorrhage, and he had more blood around the right sigmoid venous sinus. He then went on to have a venogram, which confirmed him to have an occlusion of his right transverse sinus extending into the sigmoid and the jugular bulb. So he didn't survive this injury, but it's interesting that, you know, with a man with a relatively mild radiological injury and clinical injury, you would have expected him to survive that, and it's unlikely that he would have died just simply from the contusions and the fracture themselves. So there must have been something else driving this. So there was no family history of thrombosis, and there was, you would really have expected him to survive with minimal neurocognitive effects. And so this sort of raises this possibility of why should he have gotten this cerebral venous sinus thrombosis, and how common is it? So in 2020, Bukhari had produced a meta-analysis which he published in World Neurosurgery. It contained about 13 studies with about 1,400 patients in it, of which 700 were American patients, and there's other ones with in Israel and China and other centers. They estimated the overall rate for CVST in trauma to be about 4%, but whenever you selected it out for petrous temporal fracture or occipital fracture, crossing a venous sinus was much higher, about 26%, or 40% for a petrous temporal fracture. The Royal London Group, who published in 2021, said their overall rate estimate was lower at about 1.3%. But when you delve into the data in a bit more detail in the Bukhari study, only 3 of the papers included had a full set of venous imaging on which to judge their venous sinus thrombosis rate. In the Delgado paper, which is included in the Bukhari analysis, they reported that the CVST rate in those they classified as high risk for CVST, their criteria for that was that they had a fracture that had to cross the venous sinus, and they had to have clinical signs that made them suspicious that there could be a CVST, such as seizures or papilledema or persistent headache, although it didn't seem to include persistently elevated ICP without an obvious cause. 20% of the Delgado paper patients didn't have any fracture extending into a venous sinus, and if you didn't have a fracture extending into a venous sinus, then you didn't get CVST. If there was non-occlusive thrombus, then you had no risk of venous infarction in that paper, And if you did have occlusive disease, then you had about a 7% risk of infarction. So you might say, well, this is very rare. Why do we need to do anything about it? It's not very common. The reason for that is that we don't see this very often, but it does seem to happen in even those with mild head injury. It's not really a function of the severity of the injury, and it can't simply be put down to an unsurvivable problem. There's also a bit of a disconnect between the number of patients we see with petrous fractures and those that go on to develop the problem. And we see a lot of petrous fractures and a lot of fractures that go across venous sinuses, but not necessarily a lot of thrombus. So it would be very useful to understand this in more detail. There's also the reasonable likelihood of contribution to raised intracranial pressure from inadequate venous drainage, which is, presumably a contributing mechanism for the man who didn't survive in case 1. It's also important for other reasons, and there's a significant rate of infarct whenever arising from a venous obstruction. If you were to take some of the data from the non-traumatic cerebral venous sinus data, there's a large multi-center trial in 2004 which estimated that there was about a 46% rate of venous sinus thrombosis and infarct, but although that's in contrast to Delgado's paper, which would suggest the rate was much lower at about 7%. There's also about a 30% rate of papilledema in the spontaneous group. And I know it's not really useful to necessarily conflate the data from 2 different disease processes, but they are quite analogous, and there's a lack of general data on the trauma group, so therefore we might be able to learn some or take some conclusions from the other medical data. So those that are at risk of CVST, it largely seems to be those with fractures across the major venous sinuses. It seems that if there's no fracture, then there's almost no risk of CVST. The literature is pretty vague on timing on the development of these thrombus. Case 1 developed within 24 hours, and in the third case that we'll discuss, it happened within 12 hours. In the Royal London Group's paper, they had a diagnostic scan range from 1 to 18 days, and it's a little bit unclear whether the delay in diagnosis was due to development of the thrombosis later, and whether they had previously normal venous imaging, and approximately half of the studies in the meta-analysis didn't specify the timing of the imaging. So does screening for thrombophilia have a role? Well, it sort of seems intuitive that it would be beneficial, but that may not be that easy, as there's multiple possible contributors. Trauma and infection alone are contributors, but then there's also the other ones such as protein S and C deficiency, and factor V Leiden deficiency, antiphospholipid syndrome, and in the females, the use of oral contraceptive pill could also be contributory. So it's also difficult to know how to relatively weight those contributors, and also whether it's going to actually change your decision making as to whether you anticoagulate or whether you don't. There's a number of cases with fractures across the venous sinus without thrombosis, and therefore it's not related to the severity of the impact or the degree of bony disruption, suggests quite strongly that there must be other factors that are driving this, and the only outstanding real place to look is that blood constituents. However, given our general experience of the condition, in that we don't see this very often, it seems that even though we may more fully understand the driver of the condition, it doesn't necessarily follow that just because someone has a positive risk factor, they should be treated with anticoagulation, and we still need to understand the natural history of a disease a bit more fully. So this is case 2, and this is a man in his 40s. He was previously well apart from alcohol abuse prior to injury, and he fell off a ladder, sustaining some rib fractures and pretty severe bony injury to the left side of his posterior fossa, extending into the mastoid. You can see quite significant disruption of the mastoid and fluid in the mastoid, and 2 fractures of the occipital bone. On his plain brain scan, he had quite a lot of blood in his posterior fossa around his brainstem. He had subarachnoid hemorrhage in around the basilar artery, and he had supratentorial pneumocephalus, and he had quite a lot of convexity subarachnoid hemorrhage on the right-hand side. He was managed in the intensive care unit with ICP monitor, and he eventually required an EVD for refractorily elevated ICP. And this is his day 1 scan. So you can see a lot of the injuries have really sort of matured. He's got, more evident contusions in the right hemisphere. He's got a lot of basal blood around the top of the tentorium in the pineal type region, and he's got a big left cerebellar contusion. And because of the contusion and because of the extensive fracturing, he did have a venogram, which has demonstrated, a left transverse sinus thrombosis extending into the sigmoid and down into the jugular, and he managed to get through his treatment with ICP monitoring, medical therapy, and EVD. He didn't require any surgical decompression. And we did a day 5 venogram on him, and that didn't show any progression. And at that stage, he'd been on enoxaparin for 3 days. We put him on it at 48 hours. After day 5, because we put him on to therapeutic enoxaparin. And the reasoning for that, you might ask, well, why did you do that if his thrombosis didn't progress? It was because it's quite a dominant sinus on that side. He had quite a lot of injury to the right hemisphere, and I was quite concerned that if he could develop a left temporal infarct, that could be fairly catastrophic. Although it was a fairly severe injury to begin with in radiological terms, although his GCS was fairly encouraging. So at day 13, he'd been on therapeutic Clexion, and the injuries had all started to settle down. He was extubated and eventually got discharged to the ward. And eventually we were able to discharge him home on therapeutic Clexion. He made a good physical recovery. He was a bit disinhibited, but we felt it was safe enough to go home with family support. And it appeared that quite quickly after he was discharged home, he discontinued the enoxaparin, and he didn't tell us, and the family didn't tell us. And because of his alcohol abuse, he presented to his local emergency department on a number of occasions for relatively minor head injuries. And at one point, he had a venogram, which shows, that he's extended his venous sinus thrombosis really very extensively. It involves most of the sagittal sinus, all of the left-sided system, but it spares the right-sided transverse and sigmoid and the deep system. So he's quite interesting in the sense that he was treated pretty aggressively with anticoagulation from day 5, and he had quite a prolonged period of therapeutic established, well-delivered therapeutic Clexion, but yet he progressed through that, and it's unclear as to why he did that. And although he had quite significant disruption of the left mastoid, the bone fragments didn't seem to be sticking into the sinus, and it wasn't mechanically obstructed. And with that anticoagulation, why should he progress so dramatically? And also, he didn't have any negative effects of it yet. This, in contrast to case one, the guy developed it within a short period of time and then succumbed to it. And our final case was another man who was assaulted and sustained quite a significant fracture to the left occipital bone extending into the mastoid. And he was initially GCS 14, but he improved to 15. But he had quite significant headache, and it was on the basis of a disproportionate level of headache that he underwent a venogram eventually. This is the initial scan. As you can see, the pneumocephalus in the fourth ventricle and in the left side of the posterior fossa, but very little blood around the left sigmoid sinus. Just some frontal contusions, but relatively small volume. And this is the type of injury you would be really expecting them to do, to recover from fairly effectively. And the venogram demonstrates good flow in the torcula and into the right and left transverse sinus, but there's a opacification of the left sigmoid. So he was treated with initially with prophylactic enoxaparin, and this is the decision-making algorithm that you could consider. This is taken from one of the medical papers, but essentially, if they're really unwell and they're unconscious and you think it's completely occluded, you could consider endovascular treatment. But there's really very little evidence for that, and that could be quite problematic if you have to stent the sinus open. You might have to put them on dual antiplatelets, and that's quite a big step in trauma. But in this case, he wasn't, so you could actually do nothing, or you could anticoagulate him. And of course, then you're looking at, do you have a transient risk factor? Do you have an unmodifiable risk factor, which brings in our discussion previously about screening for thrombophilia. The problem with surveillance is how often are you going to carry out your imaging, how long are you going to do it for, and are you just simply prevaricating until they develop a venous sinus thrombosis and a venous infarct, which could be fairly disabling for some people. So it's not really very clear as to how you should proceed. Ultimately, he was treated with therapeutic enoxaparin, and then he represented it roughly 2 weeks later with an intracranial hemorrhage in the right temporal lobe rupturing into the ventricles. So looking at the overall outcome of the cerebral venous sinus thrombosis in trauma, it's fairly uncertain as to whether it influences your outcome at all. There's a lot of uncertainty in the literature as to whether recanalization is important. Bokhari estimates recanalization at about 80%, but Harris's paper in 2021, which is the Royal London Group, they found it to be unchanged in about 50%, and it recanalized in like 13%. Most of their series had Glasgow outcome scores of 1 or 2, so that's quite good. And they found their overall outcome from this was really determined by your aged injury and the other factors that determine your outcome in cranial trauma rather than by the sinus thrombosis itself. So in Harris's group, they found that whenever they anticoagulated their patients, and they on average they only anticoagulated 4, and so the average date at which anticoagulation was introduced was day 13. They had no complications. But if you were to look at the medical literature, they will the neurologists will sort of anticoagulate people even with intraparenchymal hemorrhage, and there's no particular contraindication to doing that. But that isn't really the same as trauma, so have to be careful about using that as a decision-making mechanism. So when is it safe to start prophylactic anticoagulation? That's fairly safe by about 48 hours, and there's some certainly some evidence to say it's reasonable at 24 hours if your CT scan is stable. But once you get to 48 or 72 hours, then there's fairly reasonable evidence to suggest that it's safe. However, when you're when is it safe to start full anticoagulation? That's much more difficult than the answer, and nobody really knows the answer about when it is safe. We're probably going to get some evidence in the future as to whether it becomes safe from another group, and they'll be looking at anticoagulation in the elderly, usually people who have been on anticoagulation for, you know, AF or cardiac valve reasons. And there's certainly some evidence to suggest that reintroduction of the anticoagulation somewhere around 1 to 2 weeks actually is protective for them for developing complications of actual thrombosis related to the valve or the AF. So there's probably going to be a window somewhere around 1 to 2 weeks, but it's a little bit unclear as to where that will actually be. And there are a number of trials that are going to be looking at that coming out in the next couple of years. So to treat or not to treat, all of our cases provide fairly conflicting experience, and you'll have to judge it on a case-by-case basis on the facts and the relevant considerations at the time. The evidence is a bit confusing. It lacks definition and clarity and also longevity, and you're going to need to make it on the we're not going to get a choice as to whether we choose not to make it. We're going to have to make a decision even if the evidence isn't very clear. And there are a number of factors you might need to consider. They might be the extent of the thrombosis and the sinus dominance, and if there's any collateralization, the presence of other injuries and the prognosis, and you'll need to consider a previous history of thrombosis and possibly for screening for thrombophilia. But ultimately, you're going to need to involve a hematologist so that they can more accurately interpret and judge which anticoagulant you might be using and whether it's sensible to do so. There does seem to be a significant rate of recanalization, and there may be a significant rate of subclinical consequence, but there isn't. It isn't very clear at this stage. There may be a strongish case for sequential imaging and clinical monitoring pre-initiation of treatment, if that's an option for your case at the time. And that's really brings me to the end of my discussion. If there's any questions.
Phil, thanks very much, and well done for going through that. It's a really complicated topic. I think it's not an easy one. Can I just start? There's some questions, and I'll just read them out, and I'll just have some questions of my own. But I mean, just start with the diagnosis. That's probably already a difficult part. It's a bit like arterial dissections or any vascular things with trauma. Diagnosing it is actually difficult. I mean, if we see a fracture in a trauma patient going across a venous sinus or, let's say, petrous temporal bone, should we CTV all of them? Are we? I mean, I'm just the cases you presented have made me think. Sometimes you get a patient with cerebral swelling, and you're kind of wondering why on earth are they swelling, and are we missing venous sinus thrombosis as a cause of it?
Well, I think certainly we're moving in that direction, but there's a big volume of patients with petrous temporal fractures that go over towards venous sinuses that don't get CTVs and don't have any negative effects from it. But I think that really underscores the fact that we don't really understand what's driving this. It doesn't seem to be related to the magnitude of the bone disruption, so which will lead you in the direction of the thrombophilia screening. But certainly, if you're seeing symptoms or raised intracranial pressure that you can't really explain, it certainly would be something I'd be thinking about then for sure. I think that your other question about for the awake patients that aren't in the intensive care unit, then you might be able to go on their clinical progress. But then if you're managing them in other hospitals, that makes it additionally complicated, and it probably leads you more towards imaging, so that you can actually make really sensible decisions for patients that aren't in your own ward. So I think we're probably heading in that direction, at least for a significant proportion of them, yes.
Yeah, and then I'm just reading some of the questions coming through, which are similar to my own. I suppose if you, And you did kind of cover that a bit. If we do a scan and a CTV and it's saying negative on the initial one, would you repeat it? And that's one of the problems, isn't it? And when?
I think it very much depends on the scenario you're faced with. If you've got progressive symptoms or uncontrolled ICP, then I think you definitely need to do that. I'm not sure. There's a significant number of patients who don't have a problem here. I mean, most of the Royal London series, they weren't treated. They had 38 patients, they treated 4. I think there's a significant number of people who don't get treated, but there's definitely a number of patients that do or probably will require treatment. But if you think about case 2, we did treat him and it made no difference, and he didn't get any negative effects. So it's a really uncertain topic, I think.
And with the Royal London series, where you said they didn't treat, you mean they didn't fully anticoagulate them, or they didn't?
They only anticoagulated 4 patients in their series out of 40. They followed the rest of them up, and they put them on to prophylactic enoxaparin, but they didn't. They fully anticoagulate them. They only anticoagulated 4 of them.
I think that there's a comment from one of our ICU consultants, which I think is interesting. He said, "Great presentation and discussion. Does it make you think about our use of tranexamic acid?"
Yeah, that was mentioned in the Royal London paper. They didn't find any link to that. And if you look at the CRASH 3 study, there was no link there. However, I think we've got such little solid data on this that we're going to need to have a think about this in the future. It might be something we wonder about, but I think there's going to need to be some additional work on this. That's the conclusion of all studies, isn't it, really?
Yeah, because it's interesting with tranexamic acid. Wasn't it, I think, years ago, if not decades ago, they tried it for and equally recently with the ultra trial with the rebleeding from subarachs. But I know certainly some of the older studies, there were more kind of thrombotic complications. So I think it's an interesting one. Somebody says tranexamic acid is obsolete, but I think it is being used in head injured patients, whether you like it or not.
It's being given all over the place. It's like oxygen.
It's Smarties. We have Matt here, Matt Crockett, who's a interventional neuroradiologist. Matt, have you any comments on interventional neuroradiology for the venous sinus?
Yeah, look, it's a really interesting area and it's a really difficult area. And I suppose our involvement has more been so in the kind of what we'd call spontaneous kind of venous thrombosis, or, non-traumatic venous thrombosis. We're developing, we've done at least 10 venous thrombectomies in that cohort of patients. In this setting, I was actually listening, and it's a great presentation. I saw one this afternoon, head trauma with a Peters temporal bone fracture with a probable bit of clot sitting in their kind of sigmoid. I haven't had to, from an interventional point of view, and as we know, for the non-traumatic cohort, medical management first, so anticoagulation, which is obviously complicated in the setting of trauma. I haven't personally had to go and do a venous thrombectomy in a traumatic patient. We've discussed it. We've definitely been kind of and ahhing about going in and doing it in at least one patient, but we haven't had to because they were starting an anticoagulation and everything stabilized. But even from a diagnostic point of view, often interpreting the CT venogram isn't always straightforward, because you may even have like an extradural hematoma that kind of looks like it could be within or adjacent to the sinus. Yeah. So everything about the kind of the sinus thrombosis, and then there's such variation in venous anatomy. Someone with an occluded sinus could be their non-dominant sinus, they're going to get away with it, whereas someone where it's almost their solitary sinus with a very small contralateral sinus is going to really struggle to cope with that, with the venous outflow problem it causes. So I'm kind of in some ways not surprised at that kind of heterogeneity of like outcomes and differentials, because it's a very challenging kind of condition. Yeah.
Well, very good. There is a couple of other questions. Your cases were great, by the way, because you showed the 3 cases, three various treatments and various outcomes. Someone is asking what was the reason for the demise of the first case. I think it was severe swelling, wasn't it? Or
yeah, well, that's a very good question, because you wouldn't really expect him to have died from those contusions. They were fairly small volume. Now, and he was intubated, so it wasn't, you know, that it was he fixed his pupils in after 48 hours, so it was a neurological problem, and the only thing that we can really look at there, the only other lesion you can comment on is really he didn't infarct anything. I mean, there's nothing, no major infarction on the scan. Is that his sinus thrombosis generated profound brain swelling, and he herniated and fixed his pupils. So, you know, I think that was the reason for the selection of the cases, because each of them conflicts with the other, you know, and it shows, you know, how difficult life is in this scenario, you know. The last thing you don't want to you know, the first imperative is to do no harm, you know, but you know, you don't want to do harm through omission either, you know.
Yeah.
So it's very
there's
tricky.
hardly any data on decompressive craniectomy in this scenario, is there?
There's very little. There's a bit of literature on the decompressive craniectomy in the medical patients in the spontaneous thrombosis, and there's a recent guideline produced 2017 that says you should do it to help them, you know, survive. But when you're doing it in that situation, you know, they've got to be fairly bad, because how are you going to anticoagulate them immediately after surgery? It's you know, it's almost like checkmate, you know, and no moves left.
Very good. There's plenty of comments and things coming in, but we need to move on to the next presentation. Phil, really fantastic topic and great cases, and thanks so much. A lot of learning, and it's probably only a multi-center study that's going to really shed some light on this. I can't see any other way, really.
Well, I think, you know, from my side, this is something I've sort of now, you know, it's come into my sort of mind. I'll probably certainly try and see, maybe follow up some of my cases and see if some of my colleagues will do the same, and we'll see if we can get even just a few more numbers together and see how they turn out. So
sounds good. Sounds great. Thanks very much, Phil.
Thank you for having me. Appreciate it.
Not at all. We'll move on to the next presentation, which is jointly, I think, by Dr. Matt Crockett and also by Jack Henry. Jack is just done his final med exams and is going to join us as an academic intern. And he's been very prolific, I should say, in publications over the last year, even as a medical student. And he's recently submitted a systematic review on chronic subdural hematoma treatment, so he's going to present a case and a bit of a literature review, and it's called a sticky situation, glue embolization of the middle meningeal artery for subdural hematomas. Go ahead, Jack.
Thanks very much, Professor Javadpour, for having me on, and thanks, Dr. Crockett, as well. So I'm just going to talk a little bit about middle meningeal artery embolization for chronic subdural and the evidence that underpins that. And Dr. Crockett is going to present a case and talk about the technical aspects of the procedure. So I think chronic subdural has been discussed on the webinar before, so I won't belabor the background too much, but it is common. The incidence is up to 50 per 100,000 patient years, and that's probably underestimated, really, due to problems in case ascertainment in the epidemiology studies and probably underdiagnosis as well. And it is increasing due to anticoagulant usage. And perhaps kind of more importantly, the volume of cases presenting is increasing due to an aging population. And you can see that here in the projected cases are estimated to go up by kind of 10 to 20% in the UK up to 2040. And we've traditionally thought that chronic subdural is simply venous bleeding, but in reality, it's a complex inflammatory pathogenesis, and it results in a complex multiloculated membranous hematoma structure that can make evacuating them quite difficult. They traditionally occur in older patients, and they're frequently multimorbid. They're often anticoagulated, and as a result, they can be poor surgical candidates. But burr-hole evacuation surgery to date has been the mainstay of treatment. There's been a lot of discussion about medication, but obviously the mainstay of that is corticosteroids, and they're associated with side effects and deleterious functional outcomes, which I'll get to a little bit later. And embolization is kind of the new kid on the block, and it's been investigated quite a bit recently, and it's purported to be the best of both worlds. You know, you get the treatment without surgery, but you avoid the side effects of medication. Recurrence is the outcome we're typically interested in, and it's about 11% following conventional surgery with a burr hole and a drain. And the reason we're interested in is patients who suffer recurrence have increased mortality, they've decreased long-term survival, they're at risk for further recurrences, and they also suffer from more perioperative morbidity, they have more seizures, they have more subdural empyemas, and it's got quite a significant effect on their quality of life. So this is just to illustrate the kind of variety of different surgical procedures and variables that there are in the treatment of chronic subdural. You have various surgical procedures which range from minimally invasive options like twist drill or subdural evacuating port system that's commonly used in the US. And burr holes are slightly bigger. And then you also have full craniotomies or endoscopy-assisted evacuations for more complex or larger hematomas. And medication, and in particular corticosteroids, but also statins and tranexamic acid have been discussed quite extensively. And drain placement is pretty much standard of care at this point, and I'll get to the evidence for that. And then, as I mentioned, embolization, which we're discussing today, has recently had some very, very good results, both as a primary treatment and as an adjunct to surgery. But obviously the timing and all the other variables that go into that are still very much under question. There's other considerations then that have been evaluated in randomized trials. Do we elevate the head of the bed? Does that have an effect? Are they bed rested or do we promote early mobilization? Can it be done at the bedside or should it always be done in theatre? There's general versus local anesthesia, and whether it's even beneficial to reverse their anticoagulation. So what we do know is that drains reduce recurrence by about 50%. There have been 7 randomized trials since 2009, and they've had very consistent results. And 2 large meta-analyses, including our one, have shown very consistent results across both the randomized and observational evidence. And a long-term follow-up of the initial trial in 2009 by Santarius and colleagues from Cambridge has shown improved long-term survival in the drain group. We also recently found out that subdural and subgaleal drain placement are probably equivalent. And there's a pretty good non-inferiority trial that was published in Neurosurgery, the CSCH drain trial. And that quite convincingly showed that they're probably equivalent. And there's good enough observational data to suggest that subdural drains might increase the risk of brain injury when they're placed. And so you could certainly argue that subgaleal placement might be a better option. Corticosteroids, I mentioned, have been debated a lot, and they do reduce recurrence by up to 80%. And that's based on the DEX chronic subdural trial, which was recently enough published in the New England Journal. But the functional outcomes are poor. There's a poor functional outcome actually in more patients in the DEX group versus the placebo group, 16% versus 10%. And there were serious adverse events in 11% of the dexamethasone group compared to just 3% of the placebo. So the functional outcomes are worse and there are adverse events, and that kind of precludes its routine use, really. MMA embolization, there's only been a single randomized trial to date, and that enrolled only 46 patients. They compared surgery with embolization versus surgery alone, and they did show reduced hematoma volume versus surgery, which is the primary outcome. Now, they didn't show a difference in recurrence, but it's important to note really that this trial was not powered to look at recurrence. And more importantly, there was no adverse events at all in the embolization group, which is very encouraging. So in our network meta-analysis, we looked at 23 embolization cohorts and 677 patients for recurrence, with 13 studies looking at embolization and surgery and 10 embolization alone. And they were compared to all the other interventions. And you can see in the forest plot up here that really what makes the difference in these patients in terms of preventing recurrence is the placement of a drain and MMA embolization. And really the choice of surgical procedure probably doesn't matter all that much. And it's the embolization or the drain that prevents recurrence. And again, very encouragingly, we didn't find any evidence of adverse events. And we can see there's a very low rate of recurrence of just 2.3% when you compare that to 11% in conventional surgery. And that corresponds to about an 80% risk reduction. And the rate of adverse events was only 1.4%, which is very comparable to surgery and even lower in a lot of cases. Unfortunately, if it looks too good to be true, it might be. And that's because a lot of the evidence for MMA embolization to date is in single-arm observational studies without a comparator. So it's very hard to interpret those. They're consistently at a very high risk of bias, and you can see the distribution of the risk of bias in the embolization studies on the right. There's none that you would really consider low risk. The ones that are multi-arm, they frequently compare to historical controls where they'll have recently implemented embolization and be comparing them to a historical cohort that just got conventional surgery. Confounding, I have a question mark after it, because while the confounding is present, it's important to think about the direction. And what's very encouraging for embolization is that a lot of the time, they're embolizing patients in these studies who are thought to be higher risk and comparing it to patients who get conventional treatment who are thought to be lower risk. So really, it's encouraging that the embolization is in high-risk patients and they're still doing better even than the low-risk patients in a lot of these observational studies. But in reality, it's very hard to conclude much from them. We do need properly powered randomized trials, despite the encouraging results in observational data. And there's quite a lot of unanswered questions about how we go about implementing it. So one question is whether we do surgery at all in patients who are embolized, and that's quite clear cut in people who are symptomatic. We can evacuate the hematoma and remove alleviate the symptoms. But I think a common misconception is that it just halts progression, and embolization actually results in resorption of the hematoma as well. And that's quite well illustrated in this figure on the right from Ban and colleagues. So you can see the preoperative MRI on the left. You can see on the leftmost panel here, you can see a hematoma overlying the left hemisphere here. This is immediately preoperatively, and you can see by 1 month postoperatively in the middle panel, it's largely resolved and there's good resolution of the mass effect. And by 3 months postoperatively, it's actually mostly gone. And the other question is timing, whether we do that preoperatively or postoperatively. And most of the evidence is for postoperative, but there is evidence for preoperative embolization as well, and the results are comparable. And one other thing really is patient selection. So obviously we don't want to be, or it might not be practical to embolize every single patient, and it might not be necessary to embolize every patient. And that really depends on accurately stratifying patients based on their risk of recurrence and being able to determine that accurately. And we've done some work on this with the Dublin score, which we recently developed and published. So we can basically estimate their risk of recurrence based on a preoperative CT scan and their demographics. And then hopefully in future, we'll be able to allocate them to more intensive treatment like embolization, or even consider using steroids in select patients at very high risk of recurrence. And you can see the patients with a high Dublin score do have a high risk of recurrence. It is important to note that this is only a derivation and we haven't actually validated this yet. So it shouldn't really be used in clinical practice yet, but we hope it will be. I also really have a role in the design of trials. Obviously, it would be nice to be able to pre-specify subgroups of patients at high risk and to compare them across trials. And we hope that this will give them a good framework for doing so. And lastly, I just wanted to mention a little bit about the choice of outcome in studies on chronic subdural hematoma. So recurrence is traditionally the primary outcome, and it's probably the best estimate of the procedural efficacy. For all the reasons I mentioned earlier, but there are problems with it, and that's one of them is defining it, especially now that we have embolization and we have medical therapy. Can you really call something recurrence in someone who never had the hematoma evacuated, and how you define it when it is? And the other thing is at what point you call a reaccumulation simply a new hematoma. If someone has a hematoma evacuated and recovers and has a rehemorrhage 6 months later, is that really recurrence or is it a new hematoma? And how we look at that is certainly difficult to say as of yet. Another set of outcomes that's commonly looked at are functional outcomes, and these are the big advantage, of course, is that these are patient-centered, but the drawback really is that these patients are frequently multi-morbid, and there's a background rate of functional decline of these patients anyway, and it might be totally unrelated to their hematoma. And the problem that this creates is that because of this background rate, you need very large sample sizes, and that was really demonstrated in the DEX chronic subdural trial, where you had a background rate of decline of 10% in the placebo population. So it's very hard to power studies well enough to overcome that background rate and show a significant difference. And the last outcome I wanted to mention was hematoma volume, or change in volume, and the clinical relevance of this is really uncertain. And the other issue, of course, is that like all change from baseline measures, it's frequently analyzed inappropriately, and unfortunately, the chronic subdural literature is no exception to that. So in summary, chronic subdurals are very common and getting more common. And what we really know is that drain placement and corticosteroids do reduce the risk of recurrence, but obviously steroids aren't without their drawbacks. And the evidence to date for middle meningeal artery embolization is very, very promising. The risk of recurrence appears to be very low, and the risk of adverse events is almost negligible. But unfortunately, it's very hard to be too optimistic with the current evidence base, and really what we need are good and well-powered randomized trials. So thanks very much. And I think Dr. Crockett is going to present a case and discuss the technical aspects of the procedure.
Thanks, Jack. Yeah, go ahead, Matt.
Yeah, thanks so much, Jack. That was a really nice summary of the evidence behind this. I know you've done a huge amount of work in that area. I'm just going to share my screen. I'm on call, and I just got told there's a stroke on the way from James's, but I think I'll just have enough time to squeeze this presentation in. So thanks, Mohsen, for asking me to talk about this. It's a really interesting area. And I suppose as neuroradiologists, we see subdural hematomas and chronic subdural hematomas in the setting of imaging, but it's really an area that I certainly didn't know too much about until going through my fellowship when MMA embolization came up on the radar. So it's an interesting area. There's a lot of publications coming out at present on it. And we have a bit of early experience here in Beaumont. So we're going to chat through that. So first of all, I'm going to touch on the kind of theoretical basis for MMA embolization. Then, as Jack was saying, I'm going to go through a clinical case. It's actually our first case of MMA embolization that we did in Beaumont. Briefly summarize the kind of early experience we've had and go through both mine and Jack's talks in terms of an overall summary. So think back to med school. Subdural hematomas, as we all know, are caused by bleeding from veins. They're caused by bleeding from bridging veins after head trauma, after an older patient, sometimes on anticoagulation. So my first thought when I read the first paper on MMA embolization was, well, how does embolizing an artery going to affect a venous bleed? And as Jack touched on in his summary there, the chronic element of a subdural hematoma is quite a different kind of beast to an acute subdural hematoma. So when a subdural hematoma occurs, a lot of them will resolve by themselves, but in a proportion somewhere in around 20%, the process becomes a chronic one. So following the kind of accumulation of blood products in the subdural space, there's fibrinolysis of the blood products, which leads to deposition of a variety of blood products in the subdural space. And in a certain proportion of patients, for whatever reason that is, this leads to an inflammatory reaction, leads to release of multiple inflammatory mediators, which inflames the internal and external dural membranes. Once those membranes became inflamed, essentially a process of neoangiogenesis occurs, which leads to development of multiple highly permeable capillaries. These capillaries kind of grow into that external membrane, and it's these capillaries that kind of persistently and consistently rebleed. So essentially, it's kind of set up this kind of positive feedback loop where we have hemorrhage into the cavity, which leads to further release of inflammatory medias, which leads to further hemorrhage into that kind of subdural space and into the hematoma. And it's that gives us that real typical CT appearance of a predominantly low density collection with multiple petechial foci of acute blood. So how does MMA embolization work? Well, just as the dura is applied predominantly by the middle meningeal artery, these kind of thickened dural membranes are also supplied by the middle meningeal artery. And what we're aiming to do with embolization of the MMA is to kind of induce relative ischemia in those membranes, which is going to lead to reduced neovascularization and then reduced recurrent bleeds. So we're trying to basically tip the balance from kind of persistent leakage of blood products away from that to reabsorption of those blood products. So on to our kind of clinical case. So Mr. AS, he was an 87-year-old gentleman. He had a couple of falls over the preceding few weeks, but he did have a GCS of 15 with nerve deficits, and he presented with head trauma. He'd recently had a scalp SCC resected, with a scalp advancement flap and split thickness skin graft. This is his initial CT. I'll just let this play through. So we can see we're coming up to toward the vertex, and we can see he had bilateral subdural hematomas. If I just play this on a little bit further, we can see the haematoma on the left is predominantly hypodense, but does have a little bit of a more acute blood posteriorly, whereas, sorry, that's on the right, whereas the hematoma on the left is actually larger. It's resulting in a good bit of mass effect, and it's one of these hematomas where if you don't look carefully, you can kind of skip by it because it really is nearly iso-dense to the brain parenchyma. So that was his initial CT. As I said, he'd recently had a scalp flap and graft, and he also had radiotherapy scheduled in a couple of weeks. So obviously, burr hole scalp incisions and burr holes would not be ideal for the health of that flap. He was on aspirin. He had hypertension and a few other chronic conditions. So a decision was made to proceed with MMA embolization as a sole treatment in this gentleman. So what do we do and how do we do it? So we're kind of, as you know, we're catheter pushers, so I can tell you how we push the catheters. So this is our angiography suite in Beaumont, one of our two newish angiography suites, is biplane angiography suite. So these procedures, we in terms of MMA embolizations, we can do them awake or asleep. We try to do them awake, but it does depend to some extent on the kind of how cooperative the patient is. If the patient's very confused and not able to lie still, then we'll perform a general anesthetic, perform them under general anesthetic. It's pretty standard access kit. We can do radial approach or femoral approach. Pretty standard guide catheter. We use a detachable tip microcatheter because sometimes you can glue in the tip of the microcatheter into the artery. So that's got a detachable tip. So when you withdraw the catheter, the tip can stay in. We've used Glubran, which is a cyanacrylate glue product, which is modified for embolization. It's very, very similar to the glue that we're all used to using in the emergency department. It begins to polymerize when it comes into contact with any ionic materials, and it's non-radiopaque. So we need to mix it with Lipiodol to make it radiopaque, and also make sure you flush the catheter with dextrose before injecting the glue. Otherwise, it polymerizes in the catheter and it blocks the catheter. Importantly, as mentioned, patients can have this treatment on anticoagulation and antiplatelets, and that's absolutely no issue to us. So placement of the guide catheter, as I said, transradial or transfemoral approach. This is the first angiogram. So obviously the middle meningeal artery is a branch of the external carotid artery. So just a bit of back to anatomy. So you can see here, and I hope you can see my pointer, that this is the middle meningeal artery. So it arises from the internal maxillary artery. Overlying it is the superficial temporal artery, which is a very similar appearance, but it's obviously on the outside of the scalp. This is a lateral view DSA. It's probably a good time to pause and have a think about what potential complications can occur from this treatment. We know from the data available so far that it's a safe procedure. Complications can be pretty disabling, though. I've just run on this cerebral angiogram by one frame, and we can see that although we're injecting the external carotid artery, we're getting flash filling and backflow into the internal carotid artery here. So one potential complication is, and the most concerning potential complication is non-target embolization. Now, you'd want to have a pretty itchy trigger finger to reflux glue from the middle meningeal artery right back up into the internal carotid artery, but it is a possibility. But the more common or complications that we're more concerning about is non-target embolization via communications between the middle meningeal artery and the internal carotid circulation. So pretty common to have a communication between the middle meningeal artery and the ophthalmic artery. And obviously, in some people, the middle meningeal artery actually arises directly from the ophthalmic artery. So embolization of embolic material or glue into the ophthalmic artery is often or usually going to lead in blindness. The infralateral trunk is a branch of the internal carotid artery, and there's often a communication between the kind of proximal middle meningeal artery and the infralateral trunk. So embolization into the infralateral trunk can result in embolization into the ICA and stroke. And then kind of finally, there's often a petrous branch of the middle meningeal artery that comes off quite proximally also, that goes on to anastomose with the posterior auricular artery and often supplies the facial nerve. So blindness, unilateral blindness, facial nerve palsy, and stroke would all be potential complications, and we'd hope to be keeping those under 1%. So once we put the catheter into the ECA, we then negotiate a microcatheter into the middle meningeal artery. So this is a microcatheter injection into the posterior division of the middle meningeal artery. You can see the artery outlined pretty nicely. In some patients, we've noticed who have with chronic subdural haematomas, you do tend to get this kind of fluffy. You can actually pretty much see the capsule of the hematoma, and see that kind of fluffy neoangiogenesis in the wall of the capsule. So that's a really interesting kind of observation that backs up the theory behind the treatment. We always do a microcatheter injection before injecting glue, because even though you might not see those communications with the ophthalmic or the ICA on a normal angiogram into the ECA, those kind of communications can open up when you're injecting into what is almost a closed system, because the microcatheter is often the same size as the small branches of the middle meningeal artery. Okay, so once we're up there and we're happy that we don't have any abnormal communications with the ICA branches, we can go ahead and inject glue. And this is a glue injection to let this play through into the left middle meningeal artery. So on the left of the screen is a AP view, and then a lateral view on the right. So you can see that's the final. That's left with a glue cast within the posterior division of the middle meningeal artery. Now we have been taking the anterior and the posterior branches separately, because often you can get reflux if you try and inject from the kind of common route. You can get reflux back, and you can block your access to the other branch. So that was the glue injection. So just to kind of summarize, this is the pre-embolization view. So anterior and posterior MMA divisions. This is the post-embolization view. So you can see here those divisions are both completely occluded, and this is the native view where you can see the actual glue. So you can see that glue in the posterior division, a little bit harder to see in the anterior division of the MMA, but you can see little lobules of glue in those locations. So that's the procedure. If we do it awake, we do transradial access, they can almost walk off the table. The kit is cheap, glue is extremely cheap. So in terms of overall cost, it's not a high cost procedure whatsoever. So this is Mr. AS's CT scan. So just in the top left, we've got his admission scan. So this is one I showed you earlier. So larger hematoma on the left. Just of note, we decided to only embolize the one side. It was the first one we'd done. And it kind of gave us a nice little case control study, actually, just in a single patient case control study. So this is the admission CT. This is 8 weeks post embolization, so there's a little bit of resolution, but at 3 months, and very similar to the image Jack showed earlier, the left-sided hematoma is pretty much entirely resorbed. Going back out to 4 months and 9 months, left-sided hematoma is completely gone, hasn't recurred. The right-sided hematoma has slightly reduced in volume, but is still present. So he did really well. He didn't need any further surgery, and we've done a few more cases since then. We've done 9 cases in total. We've had 1 case where there's been failed access. We're still learning. It's still a pretty new procedure. Looking back on that case, I think now we could have got access. Some of these patients are pretty elderly and a pretty tortuous anatomy, so it is possible that a small cohort will be very challenging to actually get to the MMA. We've done 4 MMA embolizations as a sole treatment. 2 of those have had complete resolution, and 2 of them have a tiny residual but significant resorption of the hematoma. And then we've done 4 cases as adjuncts to surgery. I think 3 post and 1 pre hematoma evacuation. None of those have recurred so far, and we're still waiting on longer term follow-up, as it's obviously only pretty early experience. So I suppose in summary, and this is somewhat Jack has said, so what's the theory behind it? Why does it work? So we're trying to induce relative ischemia in those dural membranes and break that cycle of inflammation, neoangiogenesis, exudation, and microhemorrhage, and shift that balance back to resorption of the hematoma rather to continued accumulation. Who could potentially benefit? So two big groups, I suppose. There's a sole therapy in patients who have a reasonably sized hematoma but aren't necessarily symptomatic. Also patients who are anticoagulated. I know we've done one patient with a metallic valve who they really didn't want to stop anticoagulation in. Other patients may be poor surgical candidates, and then as an adjunct to surgical intervention, pre or post surgical embolization seems to have the potential to reduce hematoma recurrence. How do we do it? Ideally, we do it awake, femoral radial access. I mentioned PVA particles because several studies talk about using PVA particles, which we'd be kind of much less inclined to do. You don't have any control. You can get more non-target embolization, and I think from our early experience anyway, liquid embolic subglue seems to be pretty successful. We should have a very low complication rate from this procedure, so we'd be aiming for less than 1% complication rate. What's the evidence? And as Jack has very nicely summarized, it's very encouraging evidence from observational studies, but we do need randomized control studies to confirm this. Thanks.
Matt, thanks very much. That's a fantastic presentation, and Jack as well. A really nice summary of what's in the literature, all the risk factors, and then a really nice case. Just to mention, you mentioned that case was actually, as you know, one of my cases, and not only it had the recent surgery on his scalp, he'd had multiple procedures on his scalp for SCCs, and as you mentioned, he was going for radiation and skin graft and all of that. So for a case like that, it was just fantastic to have this procedure available. And the other interesting thing, as you outlined, the left side was actually the bigger side and was the more acute side, and it was the symptomatic side, and it disappeared on the scans way before the other side. It was, as I said, like a case control study. It seems to be of very low morbidity, which is great. In terms of randomized trials, either of you, there's some ongoing, I think, at the moment. Isn't that right? Is there any comments on?
I know it at least 3 or 4. Jack, you might know some of these. Like I kind of keep checking back, but I know there's several ongoing. Quite a few of them are they're using a variety of different embolic materials. Some of them are using the equivalent of onyx, which is very expensive, and I really see a huge benefit of it. I don't know when they're due to report. I'm not sure if you know, Jack, if there's any kind of on the horizon, but it should be relatively soon. I feel that the first one might report some results.
I think the earliest one is scheduled to finish recruitment in July. I don't think there's even a reporting date on it, but I think you'd have to think a year after that with how these things go. But the earliest one to finish is July, and I think that's surgery with embolization versus surgery alone.
I think, like you say, some of them are comparing different glues, and we've, as you know, Matt, have been thinking of setting up one that effectively looks at 2 arms, one for the surgical group and then one for the conservative management versus embolization, like that chapter that we showed. Anyway, there's certainly room, I think, for randomized trials, and it seems to have great promise. And I've actually transferring another patient tonight for you, so you can do it tomorrow.
More work for us. Brilliant.
Very good. I think that was a fantastic presentation. I don't see any other questions coming up. Great presentations, guys. Really clear. One comment coming from Ashraf, our colleague in Belfast. He said, thank you, a very interesting presentation centre. This is emerging and we really need an RCT. My question is, how do you decide about the suitable candidates for embolization from a hematoma point of view? Do you want to comment on that, either of you? How do you select the patients?
I suppose so from our point of view, we can do anyone and everyone generally. I suppose the main thing is, from your point of view, Mohsen, I suppose it's symptomatic versus asymptomatic, isn't it? I think from a neurosurgical point of view, obviously, like any resolution of the hematoma from embolization is going to be a relatively slow process. We're talking about over a couple of months. So if there's obviously any symptomatic mass effect, then that excludes them. What excludes them as a sole treatment, but not necessarily as an adjunct treatment.
Yeah,
so I suppose sorry.
It's difficult to come with hard and fast rules, but I suppose the surgical group, if this reduces recurrence, because as Jack showed, the recurrence rate post burr holes is about 11%, which is quite high, really. And if embolization is shown to have low morbidity and reduces the recurrence by the sort of figures that our meta-analysis shows, then you would nearly argue everyone we do burr holes on, you should embolize. Now, whether you should embolize them afterwards or 2 days later or 3 days later, nobody knows. Then in the conservatively management group, I think those who are symptomatic but not so symptomatic or have so much shift that definitively need surgery, or like the guy I'm transferring tonight, who actually has very mild symptoms, but his subdural is getting bigger and bigger and bigger on sequential scans. And actually, when I look back at it, maybe we should have actually embolized him 2 weeks ago, because he's in his 80s. The subdural hematoma is getting bigger. Clinically, he's relatively well. So there's probably scan indications and clinical indications. And what Jack and Michael Amu published with me, that article that he was talking about, and yourself, Matt, with the class, what we've called the Dublin classification or the Dublin score, which hopefully we can validate in a prospective study, and then maybe that will tell us who should be doing embolization on, because if they're high risk category, then we could embolize those.
Yeah.
Very good. Okay, if there's no other comments, and Matt, I think, has to go and do a stroke thrombectomy. Thank you very much to all the presenters, Matt, Jack, and Phil. And thanks very much for our Belfast colleagues to join. And our next meeting will be first Wednesday of next month. I think I'll leave it at that. Okay. Thanks very much, everyone.
Thanks.
Bye-bye.
Thanks.